Hi, everyone. Welcome to our weekly series on the cerebellum. Today, we will hear from Sheng-Han Kuo and his team at Columbia University who have been studying cerebellar ataxia. I will tell you a little bit about Sheng-Han. Sheng-Han is a physician and a scientist. He's an associate professor of neurology at Columbia University. He specializes in movement disorders. He's the director for the initiative of Columbia Ataxia and Tremor, an organization that brings together physicians, scientists, engineers, and the patients to advance therapies for cerebellar disorders. He's also the lead PI of the Clinical Research Consortium for studying cerebellar ataxia. He is a recipient of the Academy of Neurology John Stolk Award and the American Neurological Association Derek Denny-Brown Award. He is a very well cited physician who has been studying ataxia, and we're going to hear about the recent work that they've been looking at cognitive disorders, decision-making disorders, impulsivity in cerebellar patients. Thank you so much, Sheng-Han, for being with us.
Hey, thank you so much, Reza, for the invitation to let our team to speak in this prestigious forum. Let me just give you some background about how this come about. This project entirely come from COVID-19. When COVID-19 hit, you remember in 2020, and everything is shut down. We have basic science team and clinical research team, right? So the mouse colony was dramatically reduced, as everybody knows, and then also clinical research had come to a halt. And that's why we think there got to be something we could do. So that's why we invented telephone neurology. We create our call center to start to understand what these people are doing in their regular life. And one thing that we found out is that all the basic science, including Reza, that you published this very elaborated research on reward processing in animal models for animal models, that's role of a cerebellum. So we thought, if that's the case, how can we add value to a scientific community? So one thing we can do is to see whether this is happening in humans, right? When people who have bad cerebellum, the cerebellar ataxia, if they will have some reward processing problem, such as impulsivity and compulsivity. I'm sorry, this outside just some traffic jam, cannot control that. Anyway, so that could be impulsivity and compulsivity. That's why we started to call this patient and also get them on a run, start to understand what kind of life experience they have. So this is a line of research that we are going to share with you today since COVID-19. We have 3 different junior speakers who will talk about, well, they may not be as junior as when they started. The first speaker is Nadia Amokran. She was our clinical research coordinator, but she gets since then become a senior clinical research manager that overseeing all the clinical research for movement disorder, but she has been the lead coordinator for the whole consortium for spinal cerebellar ataxia. And she will talk to us about identifying impulsivity in cerebellar ataxia patient and share you some story that we identify in these people. The second talk will be by Dr. Roy Lin. Roy Chi-In-Lin was our movement disorder fellow at the time, but now he has become independent assistant professor, tenure track at Baylor College of Medicine, and still driving cerebellar research in ataxia research. He is going to talk about differences of impulsivity trait between Parkinson's disease and cerebellar ataxia that we have identified. So this is how the basal ganglia disorder and cerebellar disorder have different impulsivity and compulsivity. And finally, our outstanding star, Roya Lai, who was also our research coordinator at the time, but since then she had gone to the medical school at University of South Florida. So very happy that she can join us. She had taken on this very important task to looking at the decision-making process, particularly to put this people into gambling task to see what are the decision-making process. So hopefully today's talk will be very complementary to what everybody is doing in the basic science world and to bring some clinical relevance flavor. Without further ado, Nadia, you want to first talk about your part of the story?
Yes, thank you so much, Dr. Kuo. You are amazing. So I am Nadia Amrokrain. I work with Dr. Kuo's team, and you can go to the next slide. Thank you, Roya. And as Dr. Kuo mentioned, as a clinical research coordinator, running clinical trials and then switching to remote visits, I had an opportunity to take my experiences of seeing these clinical trial patients and now seeing them at home and seeing a pattern of behaviors that I thought was unique to our ataxia patients. And so we wrote and described a case series of 5 cases. And so I'll be going over those. Next slide, please. So the first case was of a 49-year-old female homemaker who was very interested in ideas of like doomsday and prepping in the like early 2010s, but that quickly escalated into isolation and hoarding. And she had a compound where she had many different sheds and different little houses that were filled to the brim with every kind of supplies that she thought might be useful for security or for bargaining. So she would have places filled to the brim with furniture, filled with hunting supplies, guns, ammunition, mechanical supplies, gasoline, salt licks, and even like entertainment things. So just like TVs and DVDs and stuff like that. And it got to the point where she would frequently get injured because she couldn't ambulate in her home safely. There was a lot of things interfering. And she also, when it was time to have a nurse come and do a blood draw for safety labs, the nurse refused to go into her home because they said it was unsafe. We also had a lot of non-compliance issues for the medication because she would lose her medication or it wouldn't get delivered to her because it would get lost or the delivery man couldn't send it. And she also had some other impulsive and compulsive behaviors that we saw. Our next case is of a 33-year-old female financial advisor who was interested in exercise and the connection it gave to her body, but it escalated to a level where she was averaging 6 hours a day of exercise of like varying intensities. And she would regularly get injuries like muscle tears that would impair our ability to accurately assess the severity of her ataxia, as well as she would make bets and gamble like with friends about like exercise challenges, but also strangers. And she also displayed an impulsivity to go travel without telling anyone and without planning. This would often lead to her getting exposed to illnesses like COVID-19 and missing scheduled appointments. Our third case is of a 38-year-old mother, a homemaker who had a daughter and a husband, and she was super obsessed with video games, specifically Candy Crush. She would spend all day playing Candy Crush, and she would ignore her daughter and her husband, and like her daughter would ask her to make lunch and she would ignore her, and this frustrated and caused a lot of tension with her husband, and she would just be very reactionary and make claims such as divorce or that she would like leave the family. And even when she was not playing video games, she was just thinking like, I can't wait to get back to playing Candy Crush. Our fourth case is of a 64-year-old former taxi driver, male, who loved to gamble, play craps. He would take money that wasn't his and he would lose it and he would lie and deceive people about it. This would cause tension with his family, with his children. And he also had some inappropriate sexual in social interactions. And ultimately it led to indiscretion and strife with his partner, and they divorced, and he lost that caregiver that was giving him a lot of support to be compliant with the clinical trials. And then our final case is a 55-year-old male patient who was just very overly concerned with like where his medication was, when am I going to take it, how long till my next dose, and he would contact all kinds of providers, us frequently, causing a lot of administrative burden, trying to respond to the same questions over and over again. And ultimately, he would just self-adjust his own treatments. And this caused a lot of tension with him and his family because they spent up to 5 hours a day discussing this. And so next slide, please, Roya. These are just 5 examples of cases where we saw this kind of impulsive behavior in these patients and how it impacted our attempt at care with them. And it prompted us to ask what kind of mechanisms are underlying this type of behavior. Next slide, Roya. At that time, the recently published animal model findings made a connection between a healthy cerebellum modulating the reward center. And so in an unhealthy cerebellum affecting and dysregulating the reward center, this would look like impulsivities in our patients. Next slide, Roya. It's well known in Parkinson's disease that there are impulsivities, and there is a common questionnaire known as the questionnaire for impulsive compulsive disorders in Parkinson's disease, as the QIP-RS, that's used to identify and track that in Parkinson's patients. So we use this questionnaire that has questions that ask, like, do you engage in activities specifically to continue the following behaviors, such as hiding what you're doing, lying, hoarding, borrowing from others, accumulating debt, stealing, or being involved in illegal acts for domains such as gambling, sex, buying, eating, performing tasks or hobbies, repeating simple activities, or taking their PD medications. We applied this along with a motor and non-motor assessment to 50 people with ataxia and 50 people with controls over the phone. That's 100 phone calls, but not just once, multiple times. Next slide, please, Roya. And we did find a difference between the controls and ataxia. So our ataxia population showed a 1.87-fold of positive impulsivities compared to our control group. And the unique aspect of this is that ataxia differed from Parkinson's disease in 3 specific domains: in gambling, hobbyism, punting, and medication overuse, which is consistent with the observations that we'd made before. Next slide, please, Roya. We also took a look at the correlation between motor using the SARA scale and non-motor symptoms with the Beck Depression Inventory. Next slide, Roya. Wait, there we go. And so actually, yeah, next slide, please. So in this first step, we're working directly with these patients as a clinical research coordinator and observing how there is this behavior of patterns that's interfering with how we can apply the best quality of treatment. We saw that there was research in animal models perhaps supporting underlying pathophysiology. And so we took a closer look with some existing tools to identify any specific differences in our ataxia population. And now I'm happy to pass it off to Dr. Lin.
Hold on a second before we move on. Thank
Yeah.
you so much, Nadia. Yeah, I just want to ask people whether you have any questions for Nadia before we move on. Okay. No?
Let me go ahead and ask one question, I guess, to start things. The difference between Parkinson and ataxia, that was very interesting to me that you mentioned that medication overuse was like off the scale, if I read that correctly.
Yeah.
Is that right?
Yeah, Roya, you want to go back on the slide? Yeah, it is.
Yep.
Yeah. What do you think that means?
Yeah, we don't really know. So ataxia, they don't really have Parkinson's. They are abusing cinnamon much more, right? Carbidopa, levodopa, but it's not commonly used in ataxia. What we find out is almost like a health, like a supplement. People use a lot of supplement, and they are different kind, and they are taking, much more than what's Bartle recommended. So that's why, I think it's just amazing to have that. We're still doing some more investigation. Yeah, but it's one of a key feature. And you say classically in Parkinson's disease, if you look at B, they usually have impulsivity and compulsivity across all different domains. So they will also have sex, buying, eating, but then for ataxia seem to be specific for the 3-domain, but not the other 3. I think Anders have some questions.
Yeah. So one question I have is, do you have any kind of brain imaging, and do you see any sort of correlations between what you see on that imaging and these symptoms?
Yeah, we didn't do much of an imaging analysis. Something that we could do. A lot of these people, they come for clinical trial, does not necessarily have imaging within Columbia, and they all use different scans in the outside place. We don't necessarily repeat MRI on every single patient if usually they have a diagnosis of different spinal cerebellar ataxia, and that this is a large trial that have been ongoing that's for Troriluzole for Biohaven. So that's why these are the usual population, and we don't necessarily have imaging. But are you thinking about structure?
Yeah, I'm thinking about to what
patient.
extent this is cerebellar dependent, and to what extent is it degeneration of other areas?
Yeah. Roy, you want to tell Anders a little bit about what we are doing now? Yeah.
Sure. So
And that can lead into your talk. Yeah.
sure. So I think one of the main project that we are doing now is to do the lesion brain mapping. In other words, we are gathering cases with cerebellar lesion, especially cerebellar stroke, and see how many of these cases under the lesion mapping that we can really figure out the brain circuitry of the reward pathway. So yeah, that's the ongoing project.
Yeah. So we didn't have much of the in my clinic, I don't really see much of a cerebral stroke because they are more in a stroke doctor, but we started to collaborate with investigator has a lot of cerebellar stroke and also cerebellar tumor. So they can help us to definitively answer the question. Yes.
Thank you.
Yeah.
May I ask a question?
Mm-hmm.
So you said medication overuse included using supplements. Did it also include like illicit drug use, recreational drug use, or alcohol consumption?
Nadia, you want to answer that?
It did not include those.
Yeah.
Okay.
It's not that common, at least people didn't volunteer for the information.
We collected in background for other studies and no one had reported it.
Yeah. And also alcohol use is particularly less in this population because everybody is so sensitive to alcohol. They make their ataxia symptom worse. So it's like a self-limiting issue.
Thank you.
Thank you.
I
Cool.
think there's another question from the chat, Lena, about the dopamine medication. So yeah, I think that's not shown in today's talk, but we did stratify because people with MSAC could be on dopamine agonist. So we did exclude those population and then did a subgroup analysis, and the domain-specific impulsivity was still present. Yeah, hope that answers your question.
Yeah, and that's a great leeway to Roy's next talk about different impulsivity trait between ataxia and Parkinson's disease.
Sure. So thank you, everyone. It's my great pleasure to be here discussing the impulsivity trait between cerebellar ataxia and Parkinson with you. As what Nadia just mentioned, in PD, usually the major concept is that the impulsivity and compulsivity is across the board, at least as was displayed on the Quibarrette scale. However, we found the domain-specific impulsivity and compulsivity in people with cerebellar ataxia. So how to study further? And that's why we were thinking about how to dissect the impulsivity further. And then one of the more common way to view impulsivity is to view it from the personality trait. So next slide, please. Because the major idea is that different sets of impulsive personality traits can drive a particular impulsive decision. For example, if a person has the impulsivity in gambling, this could be due to an inability to inhibit the reward-based motivation, the so-called motor impulsivity. However, it could also be due to the inability to consider the negative consequences after losing money. In other words, it's a non-planning impulsivity. So next slide, please. So the Barrett impulsivity scale is a scale designed to view the impulsivity from personality trait. And that was the tool that we use. The major idea of the BIS is that there were totally 6 first-order constructs, including, and each of the two first-order constructs will form the second-order construct as a single domain. So for example, the self-control problem and cognitive complexity will form the non-planning domain impulsivity. The attention and cognitive instability will form the attentional impulsivity, and the perseverance and motor will form the motor impulsivity. So next slide, please. So you may have questions like me in terms of what are the definition examples of these first-order constructs. So let me give you a more clear definition. The self-control basically refers to plans and things deliberately. The cognitive complexity means a person enjoys mental challenges. Attention means too focused on current task. Cognitive instability means having intruding thoughts. Perseverance means the idea of keeping stable lifestyle. And motor impulsiveness means acting quickly. Next slide, please. So by using BIS-11, we further investigate how the heightened impulsivity looks like between control versus cerebellar ataxia versus PD. We found that in people with cerebellar ataxia and people with PD, both groups had higher, significantly higher BIS-11 total score. In other words, more heightened impulsivity than controls. And people with PD actually have even higher than that of the cerebellar ataxia. Next slide, please. So interestingly and consistent with what we found in the first paper, people with cerebellar ataxia, the impulsivity seems to demonstrate in a more domain-specific manner. In other words, it was the non-planning part, the non-planning impulsivity that shows the significant difference between the cerebellar ataxia and control, as opposed to PD, which is represented by the blue circle. You can see that it's across the board, just like how we used QuibRS to investigate. It's across the board in non-planning, attentional, and motor impulsivity when compared to controls. Next slide, please. So how does that look like all the way down to the first order factor? By using the lasso regression analysis, as you can see from the figure, consistent with the main analysis, under the cerebellar ataxia versus control, it's the cognitive complexity domain under the non-planning part that shows the difference. As opposed to PD, each of the first order factor under each domain, in other words, self-control under non-planning, attention under attentional, perseverance under motor, sort PD out compared to control. Next slide, please. So consistent with the excellent question from Lena, we were interested in knowing whether there's any difference across different types of cerebellar ataxia, especially MSA, which is well known to have the dopaminergic system dysregulation, and people of MSAC could be on dopaminergic medication, not only dopamine agonist or carbidopa levodopa. Our result shows that there is a significant difference between each type of the cerebellar ataxia compared to control, but there is no difference across when compared with each other. So another interesting thing that we've been thinking about is that, okay, so the most fundamental idea to begin with was there is a syndrome called cerebellar cognitive affective syndrome, the CCAS, which was first described by Dr. Jeremy Schmaman in Mass General, basically reflecting a concept of dysmetria of thoughts to describe the constellation of the cognitive and behavioral symptoms or abnormality in people with cerebellar disorders, ranging from vascular tumor to neurodegeneration. So the main question that I've been thinking about is that whether the abnormal reward, the impulsivity, is actually part of the broader spectrum of the CCAS, or it represents a different category that has a unique pathway. So that's why we did the association study to see if the BIS-11 has any correlation with the total CCAS score, and there was no significance. And when stratified by those who have CCAS versus those who don't have CCAS syndrome, there was no difference either on the total BIS-11 score. Next slide, please. So our main conclusion from this paper is that impulsivity in cerebellar ataxia is uniquely driven by the non-planning trait, unlike in PD, which was across the board. And this overall suggests that the cerebellum and basal ganglia may differentially govern impulsive behaviors, with the cerebellum contributing to the brain circuitry of the impulsivity in a, again, domain-specific manner. I think that's my last slide. I'm happy to take questions. Thanks.
Let me ask about the main result, which was, if I understood it correctly, was the difference between PD and cerebellar patients were in attentional and self-control aspects of impulsivity. Could you give some examples of what that means?
Sure. Can we go back to the previous slide? You mean the first order?
Yeah.
Yeah. So I think the attentional means to focus too much on the current task. So basically, to me, that's the patient cannot. It's actually more on the compulsive part that the patient cannot really drift the attention away. When the patient think about doing something, they just keep doing it. They're just too focused on getting it done. They keep doing it over and over again. Self-control means the plans and thinks deliberately. I would say, to me, that could also be overlapping with the compulsive manner, that the patient would just need to keep mapping out the plan and then continue thinking about getting it done to achieving it over and over again. So yeah, that's my interpretation.
If I could supplement, just like in the clinic when we see this with patients, it's like they like are focusing so much on wanting to do one specific task, like answering their questionnaire, or they're like very obsessed with one specific way of taking their medication and having their daily activities done. And we're trying to instruct them to change the way that they do their daily activity to like, okay, so don't bend down to tie your shoe, like sit down to tie your shoe, but they like insist on doing it that way. And it like leads to falls in the clinic or at home. And so that's the way that we've seen it specifically.
And also the non-planning part of a domain is more, planning for something a little bit more long-term consequences, right? So Nadia was saying that, they refuse to prepare lunch for the daughter and stuff, right? So there's like a little bit more long-term consequences. They are like agnostic about that versus attentional. It's more short-term, right? Right now, if I don't, go to a bathroom, right, I have an accident and stuff. So it's also like a time scale differences in terms of impulsivity. But the cerebellum, at least from the neuropsychology domain, what we see is a more more long-term, a little bit longer-term future consequences. They are not seeing that lead to different type of decision making. And yeah, and our next speaker, Roya, is going to tell us more about that. Before we move on, any more questions? If not, Roya, you want to tell us to solve this type of question? We started to do more in-depth task. Yes.
Hello, everyone. My name is Roy Lai. I'm very honored to be speaking to all of you today. I will be talking about gambling and reduced sensitivity to future consequences in cerebellar ataxia. As we've seen in the previous talks, the cerebellum plays an important role in impulsive behavior. For example, new onset impulsive and aggressive behavior have been observed after cerebellar strokes. More specifically, people with cerebellar ataxia show increased impulsive and compulsive behaviors. And these behaviors include gambling, hoarding, and compulsive medication use. These behaviors have a significant impact on people with cerebellar ataxia as well as their family. So we wanted to see what would happen if we asked these patients to play a gambling game. Would they also show the impulsive behaviors that we found in the previous studies? And what would their decision making look like in this gambling task? The task that we used in this study is called the Iowa gambling task. It offers participants 4 decks of cards to choose from. Each time they choose a card, they get a reward, a punishment, or both. 2 of the decks are considered good decks because they produce a net gain over time. The other 2 decks are considered bad decks because they produce a net loss over time. So we see a schematic of the task on the at the right side here. Each time they choose a card, they get an immediate reward, followed by a 50% chance of getting a punishment. So for the reward, they could get $50 or $100, whereas for the punishment, they could get $50 or $250 that they lose. And again, the good decks are good because they produce a net gain over time, whereas the bad decks are bad because they produce a net loss over time. In the study, we had 60 participants with cerebellar ataxia. That included 33 with genetic ataxia and 27 with non-genetic ataxia. And we also had 30 controls. Now let's look at the results. On the y-axis, we're looking at the Iowa gambling task score, with higher numbers being better and lower numbers reflecting more risky behaviors. The x-axis is shown blocked. Block 1 is the beginning of the task. Block 5 is the end of the task. And we have controls in circles and cerebellar ataxia in squares. Overall, we see that the cerebellar ataxia group performs worse than the control group throughout the task, meaning that they have more risky behaviors. Both groups learn to improve their performance over time, which we can see from the upward slopes, but the cerebellar ataxia group never catches up to the performance of the control group. Next, we performed subgroup analyses, splitting the ataxia group into genetic and non-genetic ataxia. In panel A, we're looking at the total Iowa gambling task score, and we see that the control group performs better than both the genetic and non-genetic ataxia groups, and there's no significant difference between the 2 ataxia groups. Panel B shows a similar result, with the controls doing better than both of the ataxia groups. Next, we wanted to see if there was a correlation between gambling task scores and ataxia severity or depression. Panel A is looking at ataxia severity measured by SARA scores. And we see no correlation between gambling task scores and ataxia severity. Panel B is looking at depressive symptoms using PHQ-9 scores. And again, there's no correlation between depressive symptoms and Iowa gambling task scores. In summary, participants with cerebellar ataxia made riskier decisions than controls throughout the Iowa gambling task. Both participants with cerebellar ataxia and controls improved their performance in this task over time, but the cerebellar ataxia group never matched the performance of the controls. We saw no correlation between gambling task scores and depressive symptoms or ataxia severity, which suggests that impaired decision-making is a unique cognitive symptom in cerebellar ataxia, and it may constitute a broader spectrum of cerebellar cognitive affective syndrome. But what drives this impaired decision-making? And this question is what motivated us to do the next study. In this study, we used both the original Iowa gambling task and a modified version of the Iowa gambling task. We see that in the original task, participants get an immediate reward followed by a delayed punishment. Whereas in a modified task, participants get an immediate punishment followed by a delayed reward. And the magnitudes of the rewards and punishments are also reversed in the two tasks. In the original task, the good dex has small rewards and punishments, whereas the bad dex has bigger rewards and punishments. And versus the modified task, where the good decks have bigger rewards and punishments, and the bad decks have smaller rewards and punishments. All of that is summarized in this table. So again, the original Iowa gambling task has good decks that offer a low immediate rewards and low delay punishment, whereas the bad decks have high immediate rewards and even higher delay punishment. In the modified task, the good decks have high immediate punishment and even higher delay rewards, while the bad decks have a low immediate punishment and low delay rewards. Keeping this in mind, we can look at what different combinations of performance on the two tasks would suggest about what is driving the impaired decision-making. We already know that those with cerebellar ataxia do poorly in the original task. So we need to look at whether what the interpretation would be if they do poorly on the modified task versus if they do well on the modified task. If they do poorly on both the original task and the modified task, that would suggest that they have a reduced sensitivity to long-term consequences. We know this by looking at what is in common between the bad decks in the two tasks. So we see that both of these decks have a more favorable immediate outcome compared to their long-term outcome. So there's a high immediate reward and a low immediate punishment. If those with cerebellar ataxia do poorly on the original task, but they do well on the modified task, that will suggest that they have a increased sensitivity to rewards or decreased sensitivity to punishments. We know that by looking at what is in common between the bad decks in the original task and the good decks in the modified task. We see that both of these have higher rewards and higher punishments. Now that we know how to interpret results, we can look at the methods of the study. So all of the participants were asked to do both the original task and the modified task so that we can compare their scores on the two tasks. We have 50 participants with cerebellar ataxia and 100 controls in a 1-to-2 design. And in this slide, we're looking at the original Iowa gambling task on the left, the modified task on the right. Again, the gambling score is on the y-axis, with higher being better and lower being more impulsive behaviors. Overall, we see that controls do better than the cerebellar ataxia group in both of the tasks. It seems like both groups learn to improve their performance in both the original task and the modified task, but controls are learning at a faster rate than those with cerebellar ataxia. And by the end of the task, we see significant difference between the performance of the two groups, both the original task and the modified task. Next, we compared each participant's scores in the original task versus the modified task. For controls, we found a correlation between their scores in the two tasks. But for the cerebellar ataxia group, we saw no correlation. More specifically, for controls, we saw that they did better on the modified task than the original task. Next, we looked at the correlation between cerebellar ataxia, ataxia severity or depression, and their gambling scores. On the left, we're looking at ataxia severity measured by SARA scores. And there is no correlation between their ataxia severity and their scores on either of the gambling tasks. On the right, we're looking at depressive symptoms. And again, there is no correlation between depressive symptoms and either of the gambling tasks. In summary, participants with cerebellar ataxia showed impaired performance in both the original Iowa gambling task and the modified Iowa gambling tasks. This suggests that risky decision-making in cerebellar ataxia is driven by a reduced sensitivity to the long-term consequences of their decisions and increased sensitivity to the immediate outcomes. And because these behaviors can have a significant financial and emotional impact on these patients, healthcare professionals who care for those with cerebellar ataxia should consider screening for impulsivity and addressing impulsive traits. Thank you.
Thank you so much, Roya, for that. Yeah. Any questions?
That's wonderful, Roya. Thank you so much. Let me start the questions and ask you if we can link the second talk with your talk, because the second talk, you showed that there was a deficit in long-term consequences that was lacking. And in your study with the gambling task, is there a way to do trial-by-trial analysis so that you can quantify sensitivity to losses and gains and see if there is a dissociation between those?
Our way of looking at their sensitivity to losses and gains was like comparing their performance on the original task versus the modified task. So since they did poorly on both, it is consistent with these participants having a reduced sensitivity to long-term consequences. There's also a different way that other studies have used, such as looking at heart rate changes or the amount that these patients sweat as a way to see how sensitive they are to rewards or punishments. But we didn't choose that method because it was more complicated and wouldn't allow us to do the study remotely.
Yeah, so yeah, Reza, thank you. Iowa gambling test is really crude. We didn't really do the trial decision making because it just give us very crude composite scale. So, but that could be analyzed. We recently published a paper with Defina Shahami. We are doing much more like a specific reward trial based. I think in that paper we did do some more detailed analysis that's published Cerebellum. Oh, sorry, we didn't prepare to talk about that today. Yeah, but that could be so to us surprising. The reward processing deficit is much more robust than Defina have been seen in Parkinson's disease over the years. So we were very happy with that, and yeah. And then if you think there is opportunity to collaborate and to do more analysis, certainly let us know. We'll be happy to find a way to work together.
Sounds good. Yeah. It sounds like you're already doing sort of value function type of estimation and how they are updating their knowledge about each deck, basically, based on the feedback that they're getting. Yeah, you're already on the way.
Yeah, but could be improved to try.
So maybe there's some other questions in the audience. Please just go ahead and raise your hand and now.
No.
I had a question. For the last talk, I was curious why you were comparing the results with depression score as well. Was it sort of as a confounding factor that you were looking at, or is that a common comorbidity with cerebellar ataxia?
We've seen in previous studies that those with cerebellar ataxia have much higher rates of depression compared to the general population. So it is a very common comorbidity.
Yeah. To add to that, in the large spinal cerebellar ataxia consortium, about 20 to 25% of people that we follow that fit the major depression diagnosis. It's actually very common, and we often treat them with SSRI. So that's why we thought it has been long been considered part of a cerebellar cognitive affective syndrome. That's why we thought it's important to include, and that's usually get captured with any kind of clinical study for cerebellar ataxia. Yeah, Anders?
Yeah, so another question along those lines. How about sleep and exercise in these groups? Is that factors that play into this, and have you seen any effects on those?
Yeah, so sleep disturbance is pretty common in this group, but haven't been like an extensive sleep characterization or even like a questionnaire based. It's very lacking. So I feel like as a field, we need to do a better job. Now we started to understand the role of sleep in the cerebellum. So I think that's some kind of future direction that ataxia clinician can tap into. But yeah, but certainly could be a big factor. Exercise, people also doing all type of exercise, but it's just not easy to quantify.
Yeah.
So we haven't been. Do you have any specific hypothesis how you think exercise can affect?
No, I mean,
can do a better
I
study?
guess many people have challenges in motor behavior. So, I mean, maybe that would decrease. But then I heard you had one patient who did too much exercise as well. So yeah, no, it was like an open question. I have no idea.
Oh, so they are actually very motivated, especially people a little bit selection bias, especially people who participate in clinical trial and help with the research. Those are usually the people who do a lot of exercise, and they do different balance exercise and aerobic exercise. So in Columbia, we have two groups of physical therapists and rehab doctor doing exercise clinical trial, study aerobic and balance exercise benefit. And the preliminary data always show, exercise can improve symptoms for ataxia and stuff. So certainly in this population, more exercise can be observed. But I just have no idea how to quantify that. I mean, probably some questionnaire, how often do you do exercise? But it's also a ever-changing thing. People go into different cycles of exercise. So having challenging, but something could be considered. Yes. And I also want to take this opportunity for anyone who, because we're just starting the things that we didn't present, that we also started to create a cerebellar ataxia impulsivity assessment scale called CIA, and Roy already we already published that, and we are building different tools. But if you see any possibility for collaboration and using our patient base, very happy to help. Yeah.
Hey, so I have a question if you don't mind. On the topic of that patient who you found exercising too much to the point of self-injury, one impulsive behavior I was curious about was, did you guys see any increase in behaviors like self-harm or any sort of other like intentional physical self-injury as a result of cerebellar ataxia?
Should I take this?
Yeah.
Yeah.
Well, yeah, but like I'll just say quickly, briefly that
We do screen for it in depression scales. And our depression scales will ask about like the intention of doing a self-injurious behavior. And the majority of time, those injuries are not linked to intention.
Okay.
Yeah, so those are not observed.
Okay, thank you.
Hi, thanks for the talk. It was really interesting. I had a question. Do you have any theories about potential mechanisms for the cerebellar control of long-term planning, or why that long-term planning might be lacking in cerebellar ataxia patients?
I don't have particular. Reza, do you have a particular hypothesis on that? I say,
Yeah,
yeah.
the link to the VTA, the dopamine system, is really all we know, right? But yeah,
Yeah. And then
great.
we are doing, yeah, in my lab, we are doing more cerebellar EEG study and trying to link like a circuit dysfunction and circuit dysfunction in different type of SCA, particularly focus on impulsivity. Preliminary, we have a paper that's in submission showing that some of the symptoms could be related to cerebellar prefrontal connectivity differences as a circuit dysfunction that we may be able to observe in cerebral EEG study. But that's just the extent that we are doing. And the other thing is Roy mentioned, we are doing different lesion-based mapping, trying to see, specific area of a cerebellar stroke can cause impulsivity symptom and try to link to different area. Yeah, so those are the attempt that we are currently trying to address. But if you have some better idea, please share with us. Yes.
Frank, you have your hand up. Please go ahead.
Yes, do you hear me?
Yes.
Okay, so my question is a suggestion perhaps, or a question as well, because I've studied sequencing in the cerebellum. And so I do not know so much about ataxia, but I was wondering whether long-term insensitivity to long-term consequences is in any way related to sequencing problems that may appear or that require cerebellar functioning, so that these, like being aware of the sequence, the chronology of events, and how they will play out in the future and how they can be anticipated. We study this on the short term, but maybe you have similar effect on the longer term. But
Right.
at least the term of 1 hour of an experiment, you see deficits at least in the gambling game, as I saw.
Very interesting. Thank you. Roya and Nadia, do you have any comment on that? Can you think about any sequencing problem happening in our patient?
I think that's a very interesting idea. It's not something that I thought about. Definitely worth looking more into.
Yeah, we should have more offline discussion. Maybe you can let us know what are the specific tasks we can start to get the mechanism for that.
Yeah, you're welcome to discuss this further. I cannot stay long here, so it will be an email, but yeah.
But we are excited to prove different mechanism, right? So we will learn how the symptoms come at, and help us to understand the role of cerebellum better.
Yes, especially my research focuses on social sequences. It's closely related to reward and the effect on other people as well. So you might have a look at my publications about this. And
will do. Thank you so much. That's why we are very excited to present this to my collaboration.
June, you have your hand up. Go ahead.
Can you hear me?
Yeah.
Yes.
Okay. So I would just when you talk about the mechanism, when I look at the Allen brain, the mouse brain atlas, because I noticed that TH expression appear to be in the posterior cerebellum vermis. So I don't know what is the mechanism for that, but there is always a possibility maybe there's some dopamine production within the cerebellum. And in this patient, if there's cerebellar deficit, in addition to its connection with the BTA, maybe there is a decrease in the local, it's just a thought.
Yeah, I think that's a very interesting thought. I think that, Purkinje cell express TH is very interesting topic to think about. I don't have particular thought other than we look at some subset of these people have used dopamine medication or have used dopamine medication, particularly people with multiple system atrophy type, cerebellar type. Sometimes they will use low dose dopamine. But we don't particularly see like particular higher, but again, sample size is smaller, and then the levodopa is just non-specific here everywhere. But that's the only remote thing I can think of at this point. But certainly worthwhile to investigate further. Yeah. And maybe let's get back to Anders' idea about some sort of volumetric mapping looking at posterior vermis to see whether that's differentially affected in different cerebellar degenerative disorder. Yeah, something to think about. Thank you so much for the suggestion.
Oh, wonderful. Are there any other questions? Well, thank you, everyone. Sheng-Han, thank you so much for this. Really, I learned a lot from this presentation, and your team was fantastic.
Thank you so much for the opportunity. And yeah, looking forward to work with everybody in the field to advance the neuroscience of a cerebellum and reward.
Wonderful. Have a wonderful day, everyone.
Thank
Bye-bye.
you. Bye.